Hello there, and welcome back. This is the 6th video in the series of bone healing and pathology. And today we're going to talk about some of the metabolic bone disorders, hyperparathyroidism, renal osteodystrophy, and Paget's disease. So starting with hyperparathyroidism, this is a really good one to know, and one that I tend to think of first when I see systemic changes in the bone that looks like more than osteoporosis. Maybe the patient is younger than you'd expect for osteoporosis. Especially if you see a granular pattern to the bone appearance, start thinking hyperparathyroidism. And so knowing what we talked about in the previous lectures about parathyroid hormone, remember PTH was the calcium Nazi, what's going to be the result of hyperparathyroidism? What's going to happen when you have something causing more and more PTH just to constantly be released? What does PTH do? It's the calcium Nazi. It draws calcium out of the bones. So over time, what's going to happen? It's going to cause bones to appear radiolucent as it's losing mineralization from the bone. And you may remember a mnemonic that goes along with this disease, hyperparathyroidism. You remember that? Bones, stones, groans, abdominal moans, some of those. But just a review of the functions of parathyroid hormone, it increases bone resorption, it increases reabsorption of calcium in the kidneys, expelling phosphate. And so what's going to happen to our levels? PTH in hyperparathyroidism, that should be self-explanatory. It goes up, so PTH is going to be high. What's calcium going to be? Well, it's just constantly drawing this calcium out of bone. And so the serum calcium is going to measure high. And those two things alone are very pathognomonic for this disease. If you see high PTH and high calcium in your lab values, you know that it's hyperparathyroidism. And then what's going to happen to phosphate? I said, remember that the kidneys, think of it as holding on to as much calcium as they can at the expense of phosphate. And so if they're hyperactive and they're reabsorbing calcium from the kidneys, it's expelling more and more phosphate. Phosphate is actually going to be low. What else does PTH do? Promoting hydroxylation of that final step of vitamin D, that final step in the pathway in the kidneys. So it creates that active form of vitamin D. Now, normally an increase of serum calcium is going to reduce PTH. So the one exception to that is hyperparathyroidism. We're talking about having usually a benign tumor. Sometimes it's malignant or just a hyperplasia of the tissue causes the parathyroid hormone to just constantly produce more and more PTH. And that's why you have these high PTH levels. So it's not self-regulated anymore. All right, this little graph shows that by and large causes of hypercalcemia, this is showing hypercalcemia, by and large, it's caused by hyperparathyroidism, whether primary, classical, or non-classical. And so that's probably 85, 90%. And then you see this little sliver here that may also be hyperparathyroidism. So the largest cause of hypercalcemia, high calcium in the blood, is hyperparathyroidism. And then this was the mnemonic I was talking about: stones, bones, groans, moans, thrones, psychiatric overtones. So they develop kidney stones, osteoporosis, bone lesions. That's what we talked about with drawing minerals out of the bone. Bone lesions I'll discuss in a couple of slides here. So groans, remember, calcium affects all of the tissues, musculature, nerves, and that leads to gastrointestinal symptoms of constipation, indigestion, nausea, vomiting. It can also lead to peptic ulcers. And then moans has to do with malaise, fatigue, lethargy. Thrones refers to polyuria, polydipsia, and constipation. And then psychiatric overtones, we talked about affecting nerves as well. So it affects the central nervous system, and that can lead to confusion, lethargy, fatigue, depression, memory loss. So a lot of different symptoms associated with hypercalcemia. All right, I mentioned this on a previous slide, but let's review here. Calcium, what's that going to be in hyperparathyroidism? It's constantly drawing that calcium out of the bone into the blood, and so that leads to high calcium levels. PTH, it's hyperparathyroidism, so you should suspect that that's high. If both of these are high, boom. Here's your Captain Obvious telling you, you should rejoice. You see that in lab value, you know right away that's hyperparathyroidism, no matter what else you see. That is pathognomonic for hyperparathyroidism. Phosphorus, I said usually low. Alkaline phosphatase, I said the big one to remember for that is Paget's disease, which we'll get to at the end of this lecture, but it can be high in this disease as well. Anything that really affects bone turnover can affect alkaline phosphatase. All right, here's an example. Look at the bone in this panoramic radiograph. Where are the normal structures? We said in osteoporosis, you see that external oblique ridge stands out really strongly. But in this case, it's just gone. And all of the cortices, you see a little bit of it here, but they appear really thin. And all of the bone just has this ground glass or salt and pepper appearance. And so this is your classic hyperparathyroidism. And maybe you feel like Chris Pratt here, having no idea what ground glass means. Well, if it has kind of that salt and pepper, kind of that mixed appearance, maybe think of a frosted glass window. In some cases, it just looks like a neutral gray, not necessarily radiopaque like cortical bone or enamel, but kind of an intermediate gray. We may refer to that as ground glass. And a lot of times that means a fibroosseous lesion. But in this case, when it's all the bone that looks that way, we're talking about hyperparathyroidism. All right, another case here, and this looks really similar to that last one. We don't see the external oblique ridge. The inferior border of the mandible appears really kind of washed out, kind of gray. You see little hints of it here. But all of the bone just looks granular, ground glass. The teeth really stand out to this gray kind of salt and pepper background of the bone. And it's both bones as well. It's not just a localized lesion, but it's all over. Okay, I said I'd talk about this, that hyperparathyroidism is related to these other tumors. We call them brown tumors, lesions of osteoclasts, the reactive giant cells. Radiographically and histologically, they're going to be similar to giant cell lesions. And in fact, histologically, it's going to be really difficult to distinguish this from something like its central giant cell granuloma. Of course, the patient age, the location, remember CGCG is usually located to the anterior mandible in children, but hyperparathyroidism, usually more of a disease of adults, manifests later in life. So when you have these changes and you have multiple brown tumors, the bone just looks overall radiolucent. Maybe you get these thinned cortices. They refer to this as osteitis fibrosa cystica. I have this in yellow text because this comes up on board review questions periodically. And so know that is associated with hyperparathyroidism. And it's talking about to the overall appearance of bone, including these multiple brown tumors. And so this is the one of these diseases that we're going to talk about that leads to these distinct solitary lesions in some cases, the brown tumors. And so what are the different causes of hyperparathyroidism? Most of them, as I said, are associated with a benign tumor, a parathyroid adenoma. About 5 to 10% are going to be associated with just a hyperplasia of the gland. And then around 1%, so a fairly small amount, are going to be actually associated with a malignancy of the gland. And then they may refer to secondary hyperparathyroidism. This is going to be different than hyperparathyroidism, but we'll talk about this next, renal failure. And we already talked about vitamin D deficiency, so osteomalacia in adults and rickets in children. That can lead to kind of a constant production of PTH because for other reasons, your calcium levels are going low. But this is different from hyperparathyroidism, especially in your lab values. We said that high calcium and high PTH are pathognomonic for hyperparathyroidism. What's it going to be in these diseases? Well, calcium is going to be low to normal. Kidney failure, it's unable to hold on to the calcium as well. Vitamin D deficiency, you kind of lose that ability to absorb calcium from the gut. But calcium's tightly controlled, and so it starts cranking up the PTH once calcium dips down just a little bit. So that's why we say low to normal for those diseases. All right, now let's talk about kidney failure. What does the kidney do? Regarding calcium, kidney tries to hold on to calcium as much as possible. And so if the kidneys fail, calcium is going to decrease over time. Whereas I said, think of the kidneys as holding on to calcium while it's expelling phosphate. And so calcium is decreased, phosphate is increased. What happens as soon as calcium drops a little bit? PTH is upregulated. And so PTH is probably going to be high. And then I usually don't talk much about this, but here we're talking about glucocorticosteroids and how it increases bone resorption through these different mechanisms. And as I mentioned a couple slides ago, sometimes you can refer to this as secondary hyperparathyroidism with renal osteodystrophy because calcium is going low and PTH is upregulated. It's different than the primary hyperparathyroidism, which we just talked about. And in some cases, it's referred to as osteomalacia secondary to renal disease. And now on to Paget's disease, also called Osteitis Deformans. So your typical patient is going to be an older patient, more common in males, especially of British descent. And the common finding is that a hat doesn't fit. You can see the skull is starting to grow thick and it has this classic, what they call cotton wool appearance, kind of a cloudy appearance of bone. It's also known to affect the femur and the tibia. And then this is kind of a unique thing of it. The tibia is starting to bow outward. And so that's something that's kind of unique to Paget disease. What are we going to see within the jaws? And it can affect the jaws. And just like with the skull, it has this cotton wool appearance is the classic description of it, where it looks cloudy like this. See, this bone just absolutely does not look normal. It looks different than what we talked about with hyperparathyroidism and the granular appearance. If we just have a solitary area, sometimes fibrous dysplasia can look like this. Paget disease is a little bit more generalized than just localized to one area, but it may just affect one arch or the other. In fact, it's more common in the maxilla than the mandible. And then just like with the patient whose hat doesn't fit because his skull bone is growing in volume, the alveolar bone sometimes grows in volume. And so if they have dentures that fit previously, but then they seem like they're small because that bone is just growing, this is your classic manifestation of Paget disease. It's also associated with hypercementosis. They are more prone to osteomyelitis. And so what are our lab findings in Paget disease? Well, I kind of skipped over a couple slides ago, but this has to do with an abnormality of osteoclasts. So the inability of osteoclasts to be able to break down bone. And so I said in healthy bone, there's good bone turnover. There's osteoclasts, there's osteoblasts. They're both doing their job. But in this case, osteoblasts are functioning and they just continue to lay down more and more bone. And that's what gives it that cloudy cotton wool appearance. And that's what makes the bone grow more in volume. So how is that going to affect calcium, PTH, phosphorus? Actually, these are pretty normal. You might think low calcium because we're not unable to resorb, but calcium is tightly controlled, and so that stays relatively normal. So does PTH, so does phosphorus. And this is the one that I've said at least a couple times already. Remember that high alkaline phosphatase, especially when it's super high and other things are relatively normal, think Paget's disease before all else. Yes, it can be high in other things, but that's the big thing to remember for alkaline phosphatase. And so here's your reminder of that. ALP can be high in many instances, but when it's a really, really huge number, think Paget's disease. And that is it for this video. See you on the next one.